Greetings, this is Mirrakhimov speaking. I'm one of the cardiac anesthesiologists at the University of Kentucky, where I also serve as the director of point-of-care ultrasound within the Department of Anesthesiology. Today we'll talk about Introduction to Advanced Cardiac POCUS, Part 3. This is a good lecture for residents who want to expand their knowledge, as well as for our cardiac anesthesia and critical care anesthesia fellows. Let's get started. I have no conflict of interest to report for this presentation. The agenda for today is to review the use of point-of-care ultrasound in the workup and diagnosis of pulmonary embolism, role of point-of-care ultrasound in pulmonary hypertension, and in aortic dissection. Let's review how right ventricle responds to acute pulmonary embolism. Under normal physiological conditions, right ventricle ejects blood into low-pressure pulmonary circulation. Some cases of acute pulmonary embolism lead to acute rises in pulmonary vascular resistance and increased afterload for the right ventricle, which is usually not well tolerated by the right ventricle. This leads to RV dilation, development of tricuspid regurgitation, interventricular septal shift towards left, low cardiac output state, obstructive shock, in extreme cases, death. For the most part, echocardiographic findings with point-of-care ultrasound are largely supportive and not diagnostic of acute pulmonary embolism. Signs such as McConnell sign, RV to LV ratio more than 1, direct visualization of a thrombus are somewhat non-sensitive signs, but when present are highly specific, which is especially true if we're able to visualize the presence of the right atrial or right ventricular clot, or clot within the pulmonary arterial tree. So how can we utilize 2D echocardiographic assessment in the work of a possible acute pulmonary embolism? You want to look and compare the size of the right ventricle and left ventricle and their respective function, assess the position and shape of interventricular septum, presence of McConnell sign, intracardial thrombi, IVC size, and respirophasic variation in its diameter, presence of IVC thrombi, and presence of lower extremity deep venous thrombosis. On the top right image, you see a subcostal view. We have a dilated right ventricle, which is quite dysfunctional. Right ventricle size is greater than the left ventricle size in that particular clip. On the bottom right, you see a parasternal short axis view at the mid-peptal level, where you see significantly dilated RV, underfilled LV, and what is called a D sign, or flattening of the interventricular septum and its shift towards the left, signifying right ventricular pressure and volume overload. Let's discuss McConnell sign, which is basal RV hyperkinesis with apical sparing. Used to be considered a very specific sign for pulmonary embolism, but now we know that non-PE causes can sometimes lead to McConnell sign. Video clip demonstrating McConnell sign shown on this slide. For example, cases of non-PE related right ventricular ischemia can sometimes lead to McConnell sign. This is because the RV free wall is usually supplied by the RCA and the apical part of the right ventricle is usually supplied by the LAD. In cases of RC ischemia and non-diseased LAD, the patient can present with McConnell sign. Again, it is very important to know the broad differential diagnosis for McConnell sign. Nevertheless, it's probably one of the most specific signs on echocardiography for acute pulmonary embolism and should be known. As we discussed earlier, the presence of intracardiac thrombi is a very, very insensitive finding on echocardiography. However, when present, it gives you almost 100% specificity and positive predictive value for acute pulmonary embolism in the right clinical setting. Here you have a parasternal short axis view at the level of aortic valve, where you see that there's a large mobile clot burden within the right atrium. Here we have a subcostal four-chamber view, where you see that there's a large clot burden floating freely within the right atrium and wants to go through the tricuspid valve into the right ventricle. On the right part of the screen, you see a frozen image demonstrating you the RV outflow view, main PA, left PA, and right PA next to the ascending aorta. And you see there's a settled pulmonary embolism present. Again, when these findings are present, the specificity and positive predictive value for acute pulmonary embolism go up significantly. IVC size and collapsibility can be a useful marker of significant PE. With increased right-sided pressures, the IVC size will become more plethoric and less collapsible with respiration. Again, as a reminder, this is how our cardiology colleagues estimate CVP via non-invasive means. We can also estimate the right ventricular systolic pressure by adding tricuspid regurgitation maximal velocity. And we'll use a simplified Bernoulli equation, which is 4V max squared, and Vmax is our maximal tricuspid regurgitation velocity plus estimated CVP. In most cases, this estimated right ventricular systolic pressure will equal to the pulmonary arterial systolic pressure. This is true because most patients don't have pulmonary stenosis and right ventricular outflow tract obstruction. Please feel free to pause this video if you need more time to review this concept. Lower extremity DVT exam should be considered in patients who have high likelihood of pulmonary embolism, because approximately 90% of acute pulmonary emboli originate from femoral and popliteal veins. Ultrasound has a very good sensitivity and specificity for deep venous thrombosis. In certain patients who are at risk, consider upper extremity DVT exam, which is very similar to lower extremity DVT exam in its principle. Some high-risk patients for upper extremity DVT may include presence of PICC line, hemodialysis catheters, pacemakers, ICDs, and patients who have advanced malignancy or other procoagulant states. Deep venous thrombosis screen is relatively easy to perform. You need to use linear probe because of its higher spatial resolution. You want to scan femoral and popliteal veins, assess for vein compressibility and presence of well-formed blood clots. Again, here's how you do it. You find common femoral vein, compress, and then scan down and do the same up until the popliteal fossa where you see the popliteal vein, and again assess for the compressibility. On this video clip, you see the presence of a hypoechoic blood clot within the femoral vein. Also note that the femoral vein lacks full compressibility. In this table, you see how to differentiate between acute DVT and chronic DVT on ultrasound. Please pause the video if you need more time to review this concept. Let's do a case. We have a 53-year-old female who has history of metastatic breast cancer, and 1 week ago she underwent hip fracture surgery. She came to your emergency department with worsening and shortness of breath and leg swelling. Her vital signs are blood pressure 110/70, heart rate 110, respiratory rate 22, and oxygen saturation is 90% on non-rebreather mask oxygen. It is important to remember that she was not on oxygen at baseline. Her laboratory workup is significant for mildly elevated proBNP and troponin. Her 12-lead EKG demonstrated sinus tachycardia and incomplete right bottom branch block. On chest X-ray, there is no infiltrate and no pneumothorax. We performed a CT scan which demonstrated pulmonary emboli of the right middle and left upper lobar pulmonary arteries, and a significantly enlarged right ventricle with a ratio of RV to LV of 1:1. Because of her oxygen requirements, you admit the patient to your ICU. You switch her to high flow nasal cannula, FiO2 100% and flow of 50 liters per minute. On these settings, her ABG came back as PaO2 of 70 millimeters of mercury, PCO2 of 30 millimeters of mercury, and bicarbonate of 22. You have a medical student working with you, and he asks you which one of this option should be entertained next. Option number 1, administer continuous albuterol in the protropium nebulization. Option number 2, administer systemic methylprednisolone. Option number 3, obtain echocardiographic study with agitated saline. And option number 4, intubate the patient and initiate positive pressure ventilation. Again, please feel free to pause the video if you need more time. And correct answer here is option 3, obtain echocardiographic study with agitated saline. Option number 2 and 1 are unlikely to be effective in this particular patient. And option number 4 is potentially dangerous. It will not treat the underlying cause. So before we go in depth answering the question, it is important for us to remember the causes of hypoxemia, which include ventilation perfusion mismatch, which is usually the most common cause. You also have diffusion limitation, shunt, which can be physiological shunt, anatomical shunt, hyperventilation, reduced tension when inspired oxygen, and some ancillary mechanisms which can sometimes contribute to hypoxemia, which include high oxygen extractions, for example, in cases of septic shock and malignant hyperthermia. One of these conditions or causes of hypoxemia, when significant, is usually refractory to supplemental oxygen, which is called shunt. Again, to remind ourselves, our patient was somewhat refractory to very high flow oxygen settings such as 100% FiO2 and very high flow rates. And again, shunt can be either a physiological shunt and anatomical shunt, such as intracardiac or extracardiac. Some causes of the shunt may include atelectasis, pneumonia, and anatomical shunts, such as, for example, patent foramen valley, atrial septal defects, or extracardiac shunts, which are typically due to pulmonary arteriovenous malformation. Let's spend a few more minutes describing the VQ mismatch. Shunt and dead space ventilation represent two extremes of VQ mismatch. Again, in dead space ventilation, you have lack of blood supply through the ventilated airway. And in shunt, you have perfusion of the airway, but the airway is not ventilated. Again, some of the causes of physiological shunt include pneumonia, acute respiratory distress syndrome, and atelectasis. And anatomical shunt can be due to intracardiac shunt, such as, for example, patent foramen valley, or extracardiac pulmonary shunt, such as pulmonary arteriovenous malformation and hepatopulmonary syndrome. Let's discuss the mechanisms of hypoxemia in patients with pulmonary embolism. In most patients, it is due to ventilation perfusion mismatch. Some patients with previously undiagnosed shunt conditions due to rise in right-sided pressure, there is a possibility of reversal of flow, which will become right to left shunt, contributing to hypoxemia. One can utilize transthoracic echocardiography with agitated saline in order to diagnose the presence of a shunt. Let's discuss echocardiographic bubble study. On this slide, you have some links describing how to properly perform that. But basically, intracardiac shunt is suggested when you see bubbles on the left side within the 3 cardiac beats of agitated saline administration. An extracardiac shunt is present when you see agitated saline on the left after approximately 4 to 8 cardiac beats. It is important to remember that in patients who have no shunt and under normal physiological conditions, these microbubbles will be effectively filtered and removed by the pulmonary capillaries. As a result, when there is no shunt, you will not see agitated saline on the left part of the heart. All right, let's switch gears and talk about cardiac point of care ultrasound in pulmonary hypertension. In order to understand this important concept, first we'll have to describe what is pulmonary hypertension, review its etiology, and then we'll follow by echocardiographic assessment of a patient with pulmonary hypertension. Pulmonary hypertension, or PH, is a heterogeneous group of disorders defined as mean pulmonary arterial pressure of at least 20 millimeters of mercury or higher. Pulmonary hypertension is independently associated with worse clinical outcomes. There are 5 groups of pulmonary arterial hypertension. Group 1, which is also called PAH, or pulmonary arterial hypertension. Group 2 pulmonary hypertension, which is usually associated with left-sided heart disease. Group 3 pulmonary hypertension, which is associated with underlying respiratory diseases and hypoxemia. Group 4 pulmonary hypertension, which is associated with pulmonary arterial obstruction. In the vast majority of cases, this will be chronic thromboembolic pulmonary hypertension related to episodes of pulmonary emboli in the past. And there is also group 5 pulmonary hypertension due to miscellaneous causes. Please feel free to pause this video if you need more time to review this important slide. Hemodynamically, we can also classify pulmonary hypertension into precapillary, which is usually from group 1, group 3, group 4, and group 5, postcapillary pulmonary hypertension, which is typically group 2, and mixed pulmonary hypertension. In all pulmonary hypertension, you can see that the mean pulmonary arterial pressure will be at least 20 millimeters of mercury. In precapillary pulmonary arterial hypertension, you will have a pulmonary capillary wedge pressure of 15 millimeters of mercury or less, and pulmonary vascular resistance of more than 2 Woods. In postcapillary pulmonary hypertension related to left-sided heart disease, you'll see that the pulmonary capillary wedge pressure will be at least 15 millimeters of mercury or higher, and the pulmonary vascular resistance will be less than 2 units. In mixed group, you'll have pulmonary capillary wedge pressure of at least 15 millimeters of mercury or higher, but the pulmonary vascular resistance will be more than 2 Woods units. Please feel free to pause this video if you need more time to review the slide. Echocardiographic assessment of a patient with pulmonary hypertension also is focused on the size of the right ventricle and its function, position and shape of the intraventricular septum, presence of tricuspid regurgitation and its severity, and estimation of pulmonary arterial systolic pressure, mean pulmonary arterial pressure, diastolic pulmonary arterial pressure, and pulmonary vascular resistance. Let's discuss the tricuspid regurgitation in patients with pulmonary hypertension. There are several mechanisms for the development of tricuspid regurgitation in this population, which includes right ventricle and tricuspid valve annular dilation, tethering of papillary muscles and choriotensioning of the tricuspid valve, which further restricts the tricuspid valve mobility and affects its coaptation. Unfortunately, it leads to a vicious cycle, which leads to further RV volume overload, further dilation of the tricuspid annulus, continued worsening of the tricuspid regurgitation, reduction in cardiac output, and venous congestion. Let's talk more about the etiology of tricuspid regurgitation. We can break it down into functional tricuspid regurgitation and structural tricuspid regurgitation. In functional tricuspid regurgitation, the leaflet tissue is believed to be normal, which is not true in structural tricuspid regurgitation, where leaflet tissue is believed to be structurally abnormal. Causes of functional TR include annular dilation, RV failure, presence of PA catheter, ICD, and pacemaker leads. Causes of structural tricuspid regurgitation include rheumatic tricuspid valve disease. Again, in rheumatic tricuspid valve disease, mitral valve is almost always involved, which is important to remember. Myxomatous degeneration, Epstein anomaly, carcinoid, and infective endocarditis. Echocardiographic features of severe tricuspid regurgitation include vena contracta of more than 7 millimeters, dense jet with continuous wave Doppler, and systolic flow reversal in the hepatic veins. You can also use point-of-care cardiac ultrasound to assess the likelihood of underlying pulmonary hypertension. For example, when the tricuspid regurgitation maximum velocity is greater than 3.4 meters per second, an estimated pulmonary arterial systolic pressure is more than 50 millimeters of mercury, then your patient likely has underlying pulmonary hypertension. And again, one way how we can estimate the pulmonary arterial systolic pressure with TR-JET is by utilization of simplified Bernoulli equation, which is 4V squared plus TVP, and V squared equals to squared maximal velocity of the tricuspid regurgitation jet. Pulmonary hypertension is possible when your estimated pulmonary arterial systolic pressure is more than 36 but less than 15 liters of mercury, and when your TR max velocity is more than 2.8 but less than 3.4 meters per second. Please feel free to pause this video if you need more time to review this important slide. All right, let's talk again about the applied echohemodynamic assessment, which we can derive from the tricuspid regurgitation. As discussed earlier, we need to measure the peak velocity of the tricuspid regurgitation, as shown in this image here. Then we need to estimate the central venous pressure, usually from the IVC ultrasound, or directly if you have a central venous pressure measurement via central line. PASP, or pulmonary arterial systolic pressure, will be almost always equal to right ventricular systolic pressure because most patients don't have pulmonic stenosis or significant RVT obstruction. Again, you will utilize a simplified Bernoulli equation, which is 4V squared plus CVP. V here is the maximum velocity of tricuspid valve regurgitation. One can also estimate the mean pulmonary arterial pressure from this measurement, which is 0.61 times estimated PSP plus 2. Please pause this video if you need more time to review this important slide. There are some additional ways how we can estimate mean pulmonary arterial pressure as well as diastolic pulmonary arterial pressure with the help of echocardiography. In order to do that, you need to obtain either RV outflow view or parasternal short axis view at the level of aortic valve and focus on the right ventricular outflow tract or RVOT and pulmonic valve. In order to utilize this technique, your patient will need to have pulmonic regurgitation. You apply continuous wave Doppler through the center of this pulmonic regurgitation. The early diastolic velocity of the pulmonic regurgitation will be used to derive the mean pulmonary pressure. And the formula for the mean pulmonary arterial pressure is your early diastolic velocity squared plus CVP. For pulmonary arterial diastolic pressure estimation, you will need to utilize late diastolic velocity of the pulmonic regurgitation jet, which you'll need to square and add CVP. Please feel free to pause this video if you need more time to review this concept. Let's review some of the advanced ways how we can estimate the pulmonary vascular resistance and mean pulmonary pressures. First method we'll discuss is pulmonary arterial acceleration time, which measures the time from the onset of ejection to its peak. In order to obtain this measurement, first get either RV outflow view or parasternal short axis view at the level of aortic valve. Focus on RVOT and pulmonic valve. You'll need to use pulse wave Doppler here and place sampling gate at the level of the pulmonary valve. The value of less than 105 milliseconds is suggestive of pulmonary hypertension. You can also estimate mean pulmonary arterial pressure from this value, and the formula for that is 80 minus 0.5 times pulmonary arterial acceleration time. On the right part of the screen, you see a spectral Doppler profile of pulmonary arterial Doppler flows. On the right part of the image, you see pulmonary acceleration time, which is reduced, and also you see a notched profile, which are both suggestive of elevated pulmonary vascular resistance and afterload. One can also estimate PVR in Woods units by using so-called Abbas formula. You'll need peak TR velocity. You'll need velocity time interval through the RVOT or right ventricular outflow tract, which then you multiply by 10 and add 0.16. And again, this is a formula how to estimate PVR in Woods units. Again, especially for acceleration time, extremes in heart rate can significantly affect the validity of the results. Though this measurement was most accurate for heart rates above 60 and less than 100. Again, extremes in heart rate can affect the validity of your results. You can also use echocardiography to estimate right ventricular stroke volume and cardiac output. In order to do that, you will need to obtain either RV outflow view or parasternal short axis view at the level of aortic valve and focus on RVOT and pulmonary valve. You will need to measure RVOT diameter. There are at least two different RVOT diameters described in the literature. One is being proximal diameter, which is in close proximity to aortic valve, and the other one is a distal diameter, closer to pulmonic valve, typically within 1 centimeter. I personally prefer using the distal RVOT diameter for that matter. You will need to use pulse wave Doppler and place it within 1 centimeter of the pulmonary valve, and then trace velocity time interval. The formula for RV stroke volume is PR squared times VTI, or velocity time interval. through the RVOT. Again, to remind ourselves, the value of letter P is about 3.14. R is your radius, which is half of your diameter, and you'll need to square that and then multiply it by VTI. Cardiac output is your stroke volume times heart rate, and cardiac index is your cardiac output divided by body surface area. Normal RV VTI should be more than 18 centimeters, and when less than that, it is suggestive of low right ventricular stroke volume and cardiac output. Let's discuss the presence of pericardial effusion in some patients with pulmonary arterial hypertension. When present, it is considered to be a poor prognostic sign. Impaired lymphatic drainage, hepatic congestion, and resultant hypoalbuminemia are some mechanisms behind this association. It is interesting to note that pericardial tamponade is rare, probably because of significantly elevated right-sided pressures, and when present, it sometimes have atypical features, such as, for example, diastolic collapse of the left ventricle. Routine pericardial drainage should be avoided in patients with pulmonary arterial hypertension. If pericardiocentesis or drainage is to be entertained, it should probably be done in a very controlled environment with the presence of arterial line, pulmonary arterial catheter. Gradual drainage versus complete drainage is probably safer. It is important to remember that pericardial drainage in this population can take off the pericardial constraint from the pericardial fluid and lead to increased RV preload, further RV dilation and dysfunction, further shift of the interventricular septum to the left, decreased cardiac output, shock, and even death. All right. Finally, let's discuss point-of-care ultrasound in aortic dissection. Surface echo has somewhat limited sensitivity of approximately 60%, but much higher specificity of about 90%. Again, because of that, it should not be used as a rule-out tool, but rather a good starting measurement, given its non-invasive nature. Consider additional imaging modalities if the concern for acute aortic dissection remains after a non-conclusive point-of-care ultrasound exam. Some additional imaging tests which are available include CT angiography and TEE, or transesophageal echocardiography. There are multiple classifications of acute aortic dissection, but the simple one is Stanford classification, which divides it into type A, which affects the ascending aorta, plus minus descending aorta, and type B, which affects only the descending aorta. Please pause this video if you need more time to review this concept. Acute type A dissection represents a true medical and surgical emergency. Within the first 48 hours, the mortality is approximately 1% per every hour without the surgery. By 1 week, approximately 60% of patients will be dead. By 2 weeks, approximately 74% of these patients will be dead. And by 6 months, approximately 91% of these patients will be dead. Again, this is for medical management only. That is why surgical treatment should be entertained whenever appropriate. Let's discuss some important views. First, we talk about peristernal long axis views. You want to look for the flap of aortic dissection either in ascending aorta or in the descending aorta. You want to look and screen for aortic dilation, aortic insufficiency, presence of pericardial effusion and left-sided pleural effusion, and assess the biventricular function. We have two clips here for external long axis view. In the view on the left, you see dissection flap in the aortic root and proximal ascending aorta. You see that the ascending aorta and aortic root are quite dilated. On the right part of the image, you see again a peristernal long axis view, but you also see that the descending aorta is quite dilated, and you see dissection flap. And again, the descending aorta here is a circular structure underneath the left atrium and posterior leaflet of the mitral valve. In suprasternal view, you want to assess for the presence of the flap, extent of the dissection, and the involvement of arch vessels. In abdominal aortic views, you want to assess for the presence of the flap and involvement of the abdominal aorta, branch vessels, such as, for example, celiac axis and superior mesenteric artery. In many cases, we can distinguish between the true and false lumen with the help of echocardiography. Unfortunately, every one of these is not 100% specific, and ideally one should use multiple parameters to decide which is a true or false lumen. In general, parameters which favor the true lumen include expansion and systole, laminar flow, and smaller size. Parameters which favor the false lumen include expansion and diastole, sluggish flow, spontaneous echo contrast, and thrombus. False lumen typically appears as a larger size lumen. Please pause this video if you need more time to review this concept. Again, for abdominal aorta, you can either use phase array probe or curvilinear probe. You want to image the aorta in both short axis and long axis. Here you have different images with anatomy delineated for you and labeled. Please feel free to pause this video if you need more time to review this concept. All right, let's take a look at some images. Here you have abdominal aorta in long axis view. You see parts of the celiac axis and SMA. You can also see that there's an intimal flap within the aortic lumen. Here is a short axis of the same view, the same patient. You have dissection flap within the lumen. And in this particular image on the left, you see the dissection flap in the abdominal aorta, and you also see the surrounding hematoma and likely contained rupture of the aneurysm in the setting of aortic dissection. In addition to that, you also need to look for and quantify aortic insufficiency, assess for presence of pericardial and left pleural effusion. You also want to assess LV function and wall motion abnormality, because in some cases, the dissection can affect the coronary blood supply because they take off from the sinus of Valsalva. RCA is typically more commonly involved than the left main. Again, left-sided pleural effusion can occur because of the frank rupture versus contained rupture or reactive effusion from transudation to the aortic wall. Again, you need to assess the arch-vessel involvement with either suprasternal view or image the carotid artery and see whether the dissection flap propagates there. Please pause this video if you need more time to review this concept. In general, point-of-care ultrasound is an essential tool for PE risk stratification, specifically when RV dysfunction and RV dilation are present. You need to include DVT point-of-care exam when you are suspecting the pulmonary embolism, given it is very easy to do and can potentially be very, very informative. Point-of-care ultrasound can be used to determine the likelihood of pulmonary hypertension and aid in estimating pulmonary vascular resistance and pulmonary arterial pressure. Point-of-care ultrasound is a good starting point in many patients with suspected aortic dissection, given its low risk and non-invasive nature. Finally, I want to thank you for your attention. If you have any questions, please do not hesitate to contact me on this email address provided on the slide. I wish you all the best and good luck.